nobody ever really thinks that they're going to become dependent. The adolescent who smokes a cigarette with friends at a party or has a joint with friends at university or whatever, they aren't thinking, I'm choosing to embark on a career where it's going to become problematic. They are engaging in a behavior almost always with peers where it's the social, the immediate situation that drives the decision. And if they become a casualty of that later in their life, that's the unintended consequence that has emanated from it.
You have found the Thinking Mind podcast. This week it's Anya, and we're very excited to welcome on Professor Sir John Strang. Professor Strang is a leading clinical academic. He is the head of the Addictions Department at King's College London and is a consultant psychiatrist working in addictions treatment for over 30 years. Professor Strang's research focuses on addiction and their treatments with a particular focus on opiate addictions, and he developed and continues to expand the work on Take-Home Naloxone, a life-saving innovation for reducing opioid overdose deaths. In this episode, we talk about what substance use disorders are, what might lead someone to develop one. We talk about what can make them difficult to treat, and a little bit about how they're treated more generally. We talk about the opiate epidemic, and Prof Strang shares his insights on some of the reasons for why it might have developed, what they're like in North America versus in Europe, and why those differences might exist. And really excitingly, we talk lots about what Take-Home Naloxone is, why it's so important, and why hopefully one day it'll be as widely available as defibrillators are in public places. We also talk about what the broader issues of opiate treatment are and what aims of treatment might be. We hope you enjoy. So Professor Strang, welcome to the podcast.
Oh, really delighted to join you.
What drew you to the work that you're doing? What was your journey to where you are now as head of addictions at King's?
Yeah, no, it's something I've wondered about myself because I do now get asked about it. And so I didn't come from a medical family or anything. So I was the first person in the family to go into medicine. And I found myself attracted to those areas of medicine that connected with social issues and lifestyle. And fairly quickly, psychiatry became an area that, as a medical student, I wanted to go into psychiatry. And then I trained at Guy's and then later moved to the Maudsley. And, as those listening who are from medical backgrounds will know, you sort of move around a number of different posts. And working in the drug field, I just felt it was like I'd put an overcoat on, and it just felt like the right overcoat. It just felt comfortable. I'm not sure I ever intended to stay in the addictions field, but rather like a number of the patients that I've treated over the years, it just sort of time moved on and it just became my habit. It was. I've also very much enjoyed working in the area for a number of reasons, one of which is, contrary to popular opinion, you get some really good results when people make changes. They may turn their lives around whilst they're in treatment and may need the treatment to continue to help them having turned things around, or they may turn their lives around and manage to exit treatment. And it's sort of it's hugely rewarding to see those changes. And a lot of medicine, let's be honest about it, a lot of medicine is to do with helping people make a gain and then working out with them whether the treatment is essential to help them keep that gain or whether they can see it as a time-limited episode that they now exit. And both of those are applicable for different people at different times.
We'll pick up on some of those themes as we go. I guess as a start, how do you think about addiction, dependence, people having problems with a substance that they use? What do you see as the type of people who you would see in clinic? What are the problems that they have, or what kind of help do they need, and why?
Well, let's think about three different levels of it. And I don't think these are real categories, but they help us with our understanding of it, or they certainly help me. So there's drug use or substance use, that somebody might be using a substance. It might be of concern to others. It may or may not be of concern to the individual. And that's like an observation of fact. And it doesn't indicate there's a problem other than people are concerned about it. But within that group, and by substance, that might be anything from heroin or crack cocaine or alcohol or benzos or and it would also include behavioral disorders like gambling behavior. And from that group, there'd then be people where it was clearly connecting with problems, and that's where you'd start using phrases like a substance use disorder, where you go, hold on, this is leading to stuff that isn't so good in your health or the way your life's going. And that doesn't necessarily mean dependence or addiction. For example, if somebody becomes profoundly drunk and is then either arrested or has their wallet or purse stolen off them or is sexually abused, any of those behaviors, they're related to the substance use, but they aren't addiction or dependence. And then from that group, there'll then be a subgroup where in a way, the incorporation of the drug use into your priorities in life leads to a skewed list of priorities, where that becomes the all-important drive, where you aren't paying attention to your own well-being, to your family, to people around you. And that's when one would view that as having become an addiction or a dependence.
And what are why does it happen? As in, so what keeps someone, let's say, using a drug without it developing problems to somebody who might, say, use the drug the same amount of time in a week, but having huge problems?
It's an extremely good question, especially from someone in psychiatry, and the answers are pretty weak, to be honest. They're partly strong in the macro view, but then they're weak when you get to the specifics. So the macro view would be that there's a genetic component, there's a developmental component, and then there's the environment that you're in. So just to explain that to people listening, so if you have within your family a history of substance use disorders, you need to be aware you're at substantially greater risk than your friend whose family doesn't have that problem. And that's a hugely important issue to bear in mind, but it doesn't mean it will happen to you. It's a little bit like if you know that your family have very brittle bones and that whenever they go on a skiing holiday or play rugby, they're much more likely to get fractures, then even without there being any formal diagnosis, you'd be wise to think, I wonder whether I've got that same characteristic, or if there's a family history of mental health disorder or of heart disease and so on. So there's that genetic bit that's given. There are then events that occur during people's life that are traumatic or even just destabilizing, even without being major traumas, where there's a vulnerability to a chemical becoming part of the way you cope with it. And then finally, there's a pure environmental chance issue. If you happen to be an adolescent growing up in, let's take South London, over a period of years when heroin use or crack use or glue sniffing or any of those behaviors was just rife amongst your school group, then just by virtue of being in that class in that year, you're a hazard. And so it's a mixture of those three factors. Those are part of what, as society, we need to bear in mind. And those of us who are clinicians or practitioners, we need to look at those to say, oh, So those are part of the picture of why someone's here today and why their continued seeking for the drug and use of it has become so disproportionately dominant in their life.
This is I appreciate a really difficult question, but how do you think about the, I think, fairly dominant view in society of it being a choice? So, and with that, then the attachment of blame and stigma, and how do you think about that in your work?
Yeah, I think it's a hugely important question for you to have asked me, because there is a big choice element to it, and both as a clinician, and if I think about friends or family members, I would want to be able to influence that choice, but I wouldn't wish to withhold the help that's then needed when somebody's made a choice that I wish they hadn't done. So whether my father or your mother was a cigarette smoker or not, I wish they hadn't taken that choice if they're a smoker. Maybe it won't ever do any harm, but the chances of it doing harm are so much greater than if they just happened to make a different choice. Somebody's drinking pattern. So there is a choice element to it. I mean, on the whole, nobody ever makes... I say no. It's hard to believe that anybody ever makes the decision to become addicted. One would make the same observation about somebody drinking alcohol, smoking, gambling, any of those. You'd think, surely that was a stupid thing for them to have done because I know what then happened. But the stigma and the blame bit is a huge issue because it leads to society discriminating against not only that group, but the services provided for that group. So to take a practical example, over the last just over a decade or so, there have been either cuts or rationalisation to healthcare provision across the health service. Mental health has been disproportionately hit, or that's where the choices have been made, where reductions or easing back would occur. And within that, those cuts have been more savage within the substance misuse field. So you see an expression of those societal, institutional stigmatization in our own behaviors and practice, as well as at the individual level. When we look across medicine, a vast amount of what we do in medicine is influenced by behaviors that people have chosen to do. And our job as doctors or social workers or psychologists or whatever is to help somebody try and get more of a hold on their personal behavior to relieve those. So somebody with diabetes where they are overweight and their diet is really not what it ought to be, it'd be wrong to be saying, I'm going to withhold treatment, but it would also be wrong not to engage with that person and say, what can we do about your lifestyle and your behavior? Hypertension, heart disease, gut disorders, respiratory disease, sort of most of medicine has this there, but it doesn't have that same damaging stigma attached to it. So I think more and more we need to call it out when it occurs and try to make sure that it doesn't alter the way services are provided, and also that it doesn't stop people from presenting for care. That's the added problem that it causes.
Yeah, I guess returning to your skiing example, as in no one would argue that someone's broken leg shouldn't be set after a ski accident. But the counter argument that I often hear in return is, well, skiing's not illegal, or something along those lines, like somehow that because the choices of something that someone in society has decided is a moral or immoral behaviour, that somehow affects how we view that.
When you look at people at the point of beginning their substance use, nobody ever really thinks that they're going to become dependent. The adolescent who smokes a cigarette with friends at a party, or has a joint with friends at university or whatever, they aren't thinking, I'm choosing to embark on a career where it's going to become problematic. They are engaging in a behavior almost always with peers where it's the social, the immediate situation that drives the decision. And if they become a casualty of that later in their life, that's the unintended consequence that has emanated from it. So I think we need to be aware that these behaviors are everyday decisions and human behaviors. We might look at ways of trying to influence those decisions, but the people who've made the decision to engage in the behavior aren't immediately demonic. They are like your brother or sister, or my son or daughter. Yeah, it's an important question. It's one that we don't have very good answers to, and it's probably more helpful to look at one of the drugs that's pretty extremely used in society. So I'm going to think of alcohol as the example, where actually what you get is there's a continuum, isn't there? So there will be quite a large number of people who use it very infrequently and quite modestly. There'll be another group who use it quite regularly, but in a way that appears not to be problematic, until they discover that maybe there's some cumulative health risks that they weren't aware of, or that it may be aggravating something else. So someone whose gastric ulcer is aggravated by it or whatever. It may lead to interpersonal arguments. It may lead to financial pressures. And these are all part of what we need to bear in mind. And then there will be people where progressively the importance of the drug and the pursuit of the drug become progressively more dominant. And I'm in a clinical capacity, I'm only likely to see people when it's in that more extreme realm. So taking the alcohol example, someone isn't going to walk into an alcohol clinic and say, do you know, I like going out for a drink and I don't have a problem. So what you see in the alcohol clinic is, by self-selection, the people where problems have developed. But it's undoubtedly true that there are substantial numbers of people in those groups for all of the substances we're talking about. But going back to the earlier example of the different ways in which one would see different patterns of use, there's a preparedness for a problem to develop. I'm actually going to go way back in history for the example, because this year it's exactly 200 years since De Quincey wrote his Confessions of an English Opium Eater. And it's a book, I think, that's absolutely wonderful and explains his personal relationship and the journey he went through. And De Quincey was a close friend of Wordsworth and Coleridge, and lived with the Wordsworths. And he was already at this stage a regular opium consumer, and would have said, it's not a problem. I can take it or leave it. I just choose to take it. And then young Kate Wordsworth, who was, I think, 3 years old as a child, and De Quincey was very fond of, and essentially living in the same extended family home. She died suddenly, and he was absolutely grief-stricken. And from that point in time until the end of his life, nearly 50 years later, he was never free from his opium habit. And I was not a psychiatrist at the time treating De Quincey, but I'd hazard a guess that led to a change in the relationship, because the opium or the laudanum that he was taking had become part of a way of coping with all sorts of problems that might arise. I mean, he referred to it as the universal anodyne, so it became the way of coping with that, and then it became the way of coping with other problems. So that imperceptible drift is part of what we need to bear in mind. And it's hugely significant to public policy because people often say, well, if people are going to use, they're going to use, or if they're going to stop, they're going to stop. And the truth seems to be different. When you look at the evidence, external factors like price and availability shape our levels of use. And personally, I regard that as counterintuitive. I wouldn't have thought that it would shape the behavior of somebody with a substantial addiction problem, but it does. That when price goes down and availability goes up, levels of consumption go up and levels of associated problems, including addiction, go up. So you go, wow, this is extraordinary. So the addiction problem and the health sequelae connect with what the Treasurer decides about our national funding strategy. That's a connectedness which you don't see with most disorders that we're dealing with. Or maybe you do, but we just aren't able to see the connections as clearly.
Gosh, yeah. I guess I'm going to go back to something that you touched on in terms of, I guess, reasons why people may use drugs, or why people, let's keep it as simple as that. I mean, how common is it that it is a way to cope with, be it depressive symptoms or a trauma or a traumatic experience?
Different clinicians will give you different views on this, and I think it's a little bit like a Rorschach ink blot or whatever. That what you see reflects your orientation, as much as what's physically there in the Rorschach. Personally, I've no doubt that there are some individuals that I've seen and treated over the years for whom it very quickly became their way of coping with problems. And there'd be a similar observation if you were talking about people taking Valium to do with being in an abusive relationship at home, or any one of a number of scenarios that one could think of. But there are also people where over a longer period of time, it's become a way of coping, even though it wasn't originally the way of coping. Or that when some unexpected new insult occurs, it numbs the pain of that insult. But I don't think it explains the extent of addiction problems or substance use problems in society, but it does become part of what makes them stickier and much more difficult to get rid of. If it's become a way of coping with a problem, and it does, at one level, cope with it. I mean, it doesn't cope with the problem, of course, but that numbing of the pain. I mean, it's interesting that opiates are such effective ways of relieving acute pain. And you suddenly realize, gosh, so it relieves a psychic pain as well as a physical pain. And if your life situation has those psychic pain aspects to them, it's difficult to say to somebody, just give up that pain relief and let's see whether you're okay on your own, or let's see whether you can find other ways of dealing with it. And in a way, that's what working with people with addictions problems is to do with. Are there other ways in which you could structure your life and your relationship to the problems where you don't use this chemical as a way of doing so?
And I mean, I guess leading from that, you said at the start that people often do get better, and actually it's a field where you enjoy the difference that can be made. But I think my understanding is that it's still difficult, and that there's sort of high percentages of relapse. And I wonder a little bit about how we define treatment success, what our aims of treatment are, but also why is it that, again, as a societal perception or a perception that other people may have, is people don't get better. Yeah,
I mean, certainly one of the reasons why people have a perception that people don't get better is that for some people that's true. For some people, despite their efforts or the efforts of people around them, in family and society and treatment centres, there may be periods of light where they appear to be getting better, and then they relapse catastrophically. And those tend to be more spectacular and more visible, whereas either the family story or the newspaper article about somebody who has slowly but progressively made gains in life and has now, there's a lot of positives in their life that there weren't before. It just doesn't make the newspaper story or even the family dinner table story that it would. I was involved with some work quite a number of years ago now with a charity looking at how did we understand recovery, and we were involved with putting together a working group who met over a weekend, looking at different perspectives on recovery. And one of the things that quite struck me was how those of us who were clinicians, we tended to view recovery as being that bad things became less. So somebody's abnormal liver function might be less, or their social disorder would be less disruptive, or their involvement with crime would be less. But those of us in the group who had a personal history of having had problems and having recovered, or someone in the family having recovered, they actually saw the accrual of positives as massively more important. They said, oh yeah, that's hugely important, but what really defines Joe's recovery is that, Joe's now looking after their daughter that they'd lost contact with, and they're now on the school governor's council, and they've got a regular job where they're doing this. And it certainly taught me that as a clinician, you do need to look very much from both the patient's perspective and from the family's perspective, as well as your physical or mental state examination perspective.
Yeah. What so something about aligning, rethinking what we think the aims are, and actually figuring out what those might be for the person. What do you find gets in the way of people reaching those aims, or why can it be difficult?
I mean, we certainly don't invest enough, not just financially, but just to do with our energies and our commitment in making it easier for people to make the changes that we want them to make. So that includes, if we want people who've got into a mess that we wish they hadn't got into to get out of it, we're probably quite likely within our own family to work really hard to help them find some way of getting back into employment, or getting back into education, or reconnecting with the family that they've just lost contact with. If their children have been taken into care, for example, all those sorts of things, we would put a huge amount of effort into it for somebody close to us. And yet when you get to the societal level, it's done very grudgingly, and much more effort around there would mean that you got much better results, not only for the individual, but for us as a society as well. I mean, one of the aspects that we were talking about earlier that's worth looking at is, well, how should we see treatments and medication in that area? Is being on medication a good thing or a bad thing? I think it's a useful question, but I also think it's a stupid question. So I'll deal with why it's a stupid question first, and then I'll come back to why it's a useful question. It's a stupid question because it presumes that everybody's the same, and that there is a single answer that medications are universally good or bad. But where it's quite a good question is it forces us to think, well, what might medication do as part of the ways that one applies a leverage on the behavior that somebody's trying to change or shift. Mm-hmm. And there's lots of other, I'm going to use other examples because they help me to think about it in a different way, and I suspect they help other people. That when somebody's profoundly depressed, do I think that there's a place for prescribing antidepressants? And I'd unquestionably think, and have seen instances where I am so impressed, and when it affects family, I'm so grateful that something has eased the profound distress and appears to have set things on a much healthier direction of recovery. Do I think people should stay on their antidepressants? I wouldn't want somebody to be on a medication that they didn't need to be on, but I would hate to think that there was some legislative limit to whether you could have your antidepressant medication for 8 weeks or 6 months, or I think it really does come back into the clinical space where, I'd be saying to whoever, to the patient I was seeing, you seem really well now. Well, I wouldn't be saying you should. I'd be asking them how they were, and assuming we concluded they were really well, I'd be saying, I wonder whether the disturbance and the distress that you've had that caused that depression has now passed, and could we safely take you off your medication? And the patient and I would work out a schedule whereby you gradually taper it off, but I wouldn't be taking a moral position on it or a financial position on it. And if it transpired that as we took them off the medication, their problems re-emerged, I'd say that's a real pity, but it does seem like we should go back onto it. And this isn't to do with mental health disorders. I mean, if there was a teenager who had epilepsy and was well managed on the epilepsy medication, and 5 years later was saying, do I really need to carry on taking this? One would take the same. My lifestyle's now very different. I was out partying as a teenager. I've now got a much more stable lifestyle and sleep pattern. I'd say let's see whether we can ease off it. But if when we did that, they started developing fits again, the patient and I would conclude that that's a pity, but we need to carry on with the medication. Now, and hypertension and diabetes, you can extend that. Those other examples. Apply that to the addictions field, and you go, well, has your methadone treatment or your buprenorphine treatment or your attendance at NA groups, have these helped you get to a place where you were wanting to get to? And you then need to work out, are they essential for you to stay where you want to have got to? Or can you ease back on them, or can you even stop them? And you only find that out by a shared journey with the patients of trial and error. And when you get a signal, let's take a non-medication thing, that somebody's been attending, psychological therapy support or Narcotics Anonymous meetings or Alcoholics Anonymous meetings, and doesn't wish to continue. Well, let's check that you're still stable and okay if you disengage from it. And if not, we've learned something, so we better apply it. And I think it comes back to your stigma questions. Why do we struggle so much to apply that blindingly obvious pragmatic approach to treatments in the addictions field? It's because we get caught up in some demonic sort of view of it as a not worthy patient compared with worthy patients.
I think this links really nicely with a question that one of the listeners had. They were wondering specific, so again, about opiate treatment. So within this, we're talking about drugs like heroin, fentanyl, prescribed medications like codeine, and for which one treatment pathway is replacing the substance that someone might be using with something like methadone or buprenorphine, which is also an opiate, but is prescribed, therefore is safer, means that the person can stop any use of, for instance, injecting drugs or snorting drugs, and helps them, the idea being to re-establish into life. But so the question that the person had was in relation to long-term prescribing of those drugs, and their worry specifically was related to, for instance, in prison populations, and whether there is ever almost a substitution of that medical treatment for any other kind of psychological or social approach alongside. So whether they stay on long-term methadone at the expense of us being ambitious and trying other things that may lead to them not being on any treatment at all.
Yeah, no, look, I think it's a good question, and it's a real challenge to us at a societal level about how much are we willing to commit to address the issue and the problem. And in fact, I was involved with working with Public Health England, chairing an expert group about recovery-orientated use of medications in this field, and the issue. Well, what to avoid is to think that the medication cures people, and the medication is only what the medication is. So, and what you're really needing to know is, does this enable somebody to get more of a hold on their problems, and am I able to help them in other ways to get more of a hold on their problem, to get more grip on the difficult situations they have? And methadone and buprenorphine won't get you back to college, or won't get you back into employment. They won't stop you using the drugs that were causing the problem, but they might make it a great deal easier for you to do that. So they give an opportunity to change. Nicotine replacement's a good example. So nicotine replacement a nicotine patch doesn't stop you smoking. But a nicotine patch reduces your vulnerability to relapse. So your successful quit rate will be twice. You'll have twice the success rate with your quit attempt if it's propped up by nicotine replacement as well. Now, I don't think that the nicotine replacement is a curative medication, but if it doubles the quit rate, then gets my vote. And coming back to the earlier thing about how long should you carry on with the nicotine replacement, I wouldn't want somebody to carry on with the nicotine replacement for any longer than was necessary, but I absolutely wouldn't want them to stop it if that meant they were going to go back to smoking again. And that's the sort of thinking we need to apply to the methadone and the buprenorphine consideration. So if somebody comes in, usually at a point of crisis, and sometimes in quite a bit of social and physical mess, coming into addiction treatment, because that's often what led to the decision, I've really got to go in and sort myself out. There's an initial phase when you are helping them sort out, you're patching up the wounds, or you're treating the wounds or whatever. There's then a crucial point where you're working out with somebody, where are we going to get to? What are we going to achieve? And if the treatment service you're looking at is just dispensing these medications and not engaging in those wider issues, then it does actually provide some benefit, but it's a pretty thin benefit compared with if it's also looking at how does it help you deal with relationship issues, there isn't a fixed set of problems that you deal with, but whatever you have as your packet of problems, you work out with the agency how to deal with them. I think we're pretty rudimentary in what we provide in this country, but there's been a major report recently from Dame Carol Black about our treatment system is not fit for business, and that what's required is a huge funding investment, which has been approved. And I know that Dame Carol's way, I hope it's permissible to say this, but I know that her worry is that it'll just lead to more of what we currently have. And what is required is for the the quality of what is offered to people, the breadth of the type of help is lifted up so that it helps people get back into employment, get back into stable housing, get back into spaces where they can feel more valuable and contribute more valuably. So I think your colleague's correct in challenging the notion that the medication is all that it's about. That would be a very shallow view of it. But it is profoundly helpful to people in getting out of the situation they are. But it's the work beyond that becomes crucial and where we're often pretty weak at.
Sticking along the medication theme, I wonder if I could pick your brains on Take-Home Naloxone, because I think I can't.
Oh, right, yeah.
I can't. I mean, it's one of the things I was most excited to hear you talk about, because it's, yeah. I'll leave the floor to you. Yeah.
Well, as you know, for the wider audience, since this is a conversation between two people at the Maudsley and the Institute of Psychiatry, Psychology and Neuroscience, I mean, the concept was essentially born here. It was it should have stamped on it, born in Camberwell or something. But that it really came out of the whole harm reduction movement, which was realizing that there were ways of working with people that might tackle the harms and reduce the damage that was done, particularly around, could you shift people away from injecting drugs, or shift them away from sharing needles and syringes, or shift people away from having unprotected sex. So it was born from HIV concerns originally. And a number of us were then involved with brainstorming, were there not other harms that occurred where actually we could see a change that should happen? And at a public policy level, we were doing some research work in the Institute, looking at when did overdose deaths occur and what were the predictors. And it just suddenly struck me, one of those moments where you just realize why have I never connected the fact that I actually do know what to do if somebody's there dying of a heroin overdose. If I have the complete medicine kit with me, I just take the naloxone out, give them naloxone, and their life is saved in about as miraculous a way. It's comparable to defibrillation of somebody with a heart attack. And why on earth have I never thought, or dealing with somebody who's dying of an allergic reaction and you've got an EpiPen, and why have I never thought before that I need to take that technology and think of ways of making sure that technology is there for when the crisis occurs? And in a way, in that moment, the idea of Take-Home Naloxone was born. And you think, oh yeah, so how on earth would I do that? And who are the people who might be there? And it's friends and fellow drug users, or it is, if it occurs in a family home, it would be parents or brothers and sisters. And if you think of the EpiPen analogy, if somebody has a life-threatening allergy, it would be negligent not to be talking with them about how to deal with their own allergic reaction. Or if it was one where they were going to go unconscious, you better make sure that their flatmates, their parents, their brothers and sisters knew how to deal with that situation. And that became the notion that which is now endorsed by World Health Organization, United Nations, pretty globally. Actually includes endorsed by Donald Trump, but that's not one that I normally cite. That is one of his pillars of the response. But you go, this should be part of whatever else you're doing, dealing with somebody. So this is specifically an opiate problem, so especially like a heroin problem or a fentanyl abuse problem, that you need to prepare the person, their peer group, the family, for how to deal with the emergency that you hope never occurs. But if it does occur, here's the very simple intervention. and it's slightly more than having naloxone. It's actually teaching people you need to check somebody's breathing, that their airway's clear. You need to put them in the recovery position, and you need to give them naloxone. So I'm not wearing it today, but we have a T-shirt which goes A, B, C, naloxone, and A is the ambulance, B is checking the breathing, and C is the third letter of the recovery, and then the naloxone. And in a way, it's hard to see why you wouldn't want any family who has a son or a daughter that has any involvement with heroin use at all to have this at home and to know how to deal with it. Doesn't even need to be someone whose use has become problematic yet. If my neighbour said to me, my son's hanging around with a group where I think they're involved with heroin use, what do I do about it? I'm not sure what. I would try and be supportive and come up with some constructive suggestions. But one thing I would definitely say is, you better know how to deal with a heroin overdose. If you open your son's bedroom door and he's not breathing, but he's still alive, you can save his life in the 20 minutes that you're waiting for the ambulance to turn up. So that, with some help from Quentin Tarantino and Pulp Fiction in terms of getting it into public consciousness, that sort of very much became an idea for how it should be rolled out nationally. Am I allowed to do something completely scurrilous in this?
Give us the dirt. Go on.
I think Quentin Tarantino got the idea for the overdose scene from Pulp Fiction from us. Now, you might think the guy's completely lost his marbles, but Quentin Tarantino had finished doing Reservoir Dogs, I think it was, and he'd moved to Amsterdam, and he would periodically visit some friends in North London and would crash out for the weekend and then go back to Amsterdam over the year when he was writing Pulp Fiction. And he shared and the house that he would crash out in, one of the researchers working with me was in that same house and was doing some of the very early work we were doing around. We wrote a BMJ editorial, which was a sort of manifesto about Take-Home Naloxone. And in the year when we were working on that, I don't know, but I imagine that over breakfast or whatever, my colleague was saying, these crazy guys at work have got this idea that you could teach drug users, you could give drug users an antidote for heroin, and that they could drive round to each other and save each other's life with this big injection of heroin. And Quentin Tarantino then goes off to his room and scribbles down in his diary. I obviously don't have the documentary evidence that that's true, but it's a nice thing. I think it might have been true.
We'll send him the bill. It's entered kind of public consciousness in a nice way. I don't know if you've come across the teen show Euphoria, but it's talked about there quite a lot and seen, and I guess that reflects what you're saying about this is something that people want, like as in non-professional medical people want access, want to be able to help.
Yeah, I'm hugely pleased to see how it has entered that public space, because in a way, some of the simpler conceptual steps was to say that care workers in hostels should have access to it, or teachers, in a boarding school should have access to it, or things like that. And you think, and those have their conflicts with them, but you go, yeah, we better find a way of sorting this out, because on what grounds would you justify that you weren't able to save somebody's life just because you thought it wasn't nice or whatever, But when you then start going, oh, so are you really saying that people who might be involved with drug use might also have concern about others and a sense of citizenship? It sort of conflicts with a sort of polarized view of the world. But then when it's somebody who's close to you, you realize, I actually know they may be conflicted about their behaviors, but they still do care about the next person. And when we looked at it, we found huge amounts of interventions that drug users did when someone else overdosed. Very often they were the wrong things, but that's because we hadn't taught them what the right things were. A little bit like, if somebody was having a fit and people would say to stick a spoon in their mouth or something, and then you realize that wasn't such a smart move after all. But teach people what the right things are. And we worked with Red Cross and with WHO about developing guidelines for it. Then a big step is from my point of view, it was a very interesting development. We realized the fact that naloxone was an injectable drug was a real obstacle, because you'd meet sort of ministries of health around the world sort of saying about how might you introduce take-home naloxone. And in some countries, they'd embrace it and they'd distribute sort of pre-filled injectable, rather like an EpiPen, but just not quite as neat. But other countries would go, no, this is a step too far. You can't give an injectable drug to this population. And you go, no, it has no abuse potential. If anything, it has an anti-appeal. Right? But there'd be countries who go, no, it would not be acceptable. And we realized that pharmaceutically, you could create a concentrated nasal spray, so it didn't need to be an injection. And then we had a really difficult time getting anywhere in industry, from the pharmaceutical industry, to be sufficiently interested. So there'd be, I would meet with a company, I'd ring them up and they'd say, oh yeah, you're a leading addictions expert and you think you've got a new treatment. Yeah, we'll come down, we'll see you tomorrow. We'll see you tomorrow. And then they'd say, and how often does it get given? And I'd go, well, hopefully it never gets given. And then they go, and is it a very expensive drug? And I'd say, no, it's a really cheap drug. And and their level of interest were, as a financial venture, it wasn't very attractive. But we eventually, companies did emerge, and we now have approved concentrated naloxone nasal sprays. So there are now countries that have introduced take-home naloxone. So Sweden last year, they now have a network of provision of take-home naloxone because we managed to get it converted into a nasal spray. The next twist, I'll stop on this because I could go on this one for too long, but the next twist is there's a real challenge about the fact that sometimes, people don't realize they are overdosing themselves, rather like people don't realize they're getting drunk, that the nature of it is that your judgment isn't to be relied on, and that you might be alone, or other people might think you're all right and that you're just sleeping, and actually you're slipping into coma and dying. And so the work we're currently doing, which connects with the overdose, with the take-home naloxone work, is, are there not wearables that we could have so that my Apple Watch not only tells me whether I've had a fall and I need to call for help, but also detects that I'm not breathing and they better send an alarm out. And those, we know those are achievable. I mean, we can do it in the laboratory or in a clinical research facility. Obviously, you can't say to somebody, as a drug user, you've got to take a hospital trolley around with you with all of the kit on it. So somehow we have to miniaturize it. But you start thinking, wow, that there are people we can think of either because we know them individually or because they're famous celebrities who've died, who, if they were wearing a sort of Fitbit that detected that breathing had stopped, they would probably still be alive today. And so that's the work we're currently working on, which we hope we'll be able to bring as prototype products to the clinical sphere in the next few years.
So you've talked about studying it in the lab. What happens to the body in an overdose? Yeah, what are you picking up with the wearables as well then?
Yeah, it's actually hugely interesting. And this will be, I suspect, of more interest to those listening who are medics. I mean, I hope it's of interest more widely, but we actually took a decision. I was quite keen a few years ago to improve the quality of the science on which we're basing some of these overdose interventions, because it's as if the stigma issue that we were talking about earlier has affected how seriously we study it. So there's nothing new about heroin overdose. Heroin overdose deaths, you got more than a century of heroin overdose deaths, and you'd have thought we knew everything about what happened in those overdose deaths, and we don't. But by observation, there seem to be two different types of overdose death. One is a gradual overdose death, which would particularly happen with oral medicines. So if somebody took more of their morphine than they ought to, they are likely to go into shallower and shallower breathing, and they may be found dead in the morning because it became so shallow that it didn't sustain life. But with intravenous drug use, you get a very different, you get what physiologically you'd expect. You get an instant change. And how does that show itself in respiratory patterns? So in what seemed at one level to be the logical bit of research work, but is a little bit, it's like extreme sports. This is like extreme research, and we thought we should bring people in who were known heroin users injecting heroin into a clinical research facility. So like a cross between an intensive care ward and a laboratory. And we should study them while they injected heroin, and we should hook them up to oxygen, measuring their ventilation, their pulse oximetry, their expired carbon dioxide, what sort of wired in every sense. And what we see is a very distinctive pattern of abnormal breathing. So somebody's breathing before they inject the heroin will look pretty normal. Maybe they're breathing at 10 or 12 breaths per minute. Their oxygen saturations are normal. Their carbon dioxide levels are going up and down. You'd look at it and go, oh yeah, that's what you meant to see. They then inject heroin and the breathing becomes a bit shallower, but you get complete apneic episodes. So, for those non-medic, that means you stop breathing. It's as if the wiring loop in your brain, the wire that connects to the bit that says don't forget to breathe, it's as if that wire's just come undone. And for a period of about a minute, people just completely stop breathing, even though they're awake and able to talk to you. And then it connects again. And rather like in the Pulp Fiction film, they will suddenly gasp and start breathing again. And then, a few breaths later, they'll have another apneic episode. And you go, wow. And those are, and the work we're doing at the moment, those seem pretty easily detectable. And we obviously haven't studied an overdose death when it's occurred, and we hope never to do so. That would be pretty catastrophic. But we presume that it's just a more profound drop. I mean, we have people whose oxygen saturation levels, which, again, for the non-medical listener, your oxygen levels ought to be somewhere between 90 and 100%. They should be well above 90. And we have people whose oxygen levels drop to 70 and then bob back up again, and you go, wow, this shouldn't happen. And you're in danger zone, and you start thinking, why can't we develop a sensor? And the discrimination bit, the stigma bit comes in here. I guess it's because compared with detecting other disorders, it's just the moral issue comes in, and people just don't think. I wonder whether you could develop this to prevent heroin overdose deaths.
But the issue is, this is something Dr. Roberts said to us a few weeks ago, that drug deaths in the UK or England are the highest that they've been since recording started.
Yeah, and I mean globally, something pretty horrific is occurring, and as people concerned with healthcare and as people concerned with society, it's happening on our watch, and we're not noticing it. More people die from drug overdose deaths, the vast majority of which are heroin or opiate overdose deaths from road traffic accidents. But drug overdose deaths overtook road traffic accidents like a decade or so ago and are continuing to go up rapidly while road traffic accidents go down. I mean, the US situation is horrific. In the US, they've now passed 100,000 deaths per year from opioid overdose.
Wow.
And, they were worrying about, 20 to 30,000 deaths. And the US is a particularly extreme example, but the US and Canada, actually, so it's not just the US and Canada, but other countries, and the UK is included in that, have this steadily growing problem. It's puzzling. It's not obvious why it's occurring. And it occurs, well, some bits of it are, I mean, it's connected with the drug use that causes the overdose, but why that should be leading to such a higher proportion of overdoses and fatalities. Going back to earlier points you're asking me about, this is what makes it so intriguing. Here's something very physiological that connects with something to do with the injecting of either a diverted, prescribed, or an illicit substance that connects with social situation and supports around you. But it also seems to connect, that you get huge geographical and regional differences. So it's much more of a problem in Northern Europe than in the Mediterranean countries. I don't know why, and if you interview someone else and they do know why, I'd be grateful if you'd tell me. But I mean, there's a huge amount that we have done, and there's a huge amount more that we need to do. But people are being creative and thinking about it. So so we now have, because police might be the first people who find somebody who's had an overdose. Police in parts of the country are now trained in how to manage an overdose and carry naloxone nasal spray with them. And you go, wow, I hadn't thought of police in that way. And, and firefighters in the US do, because firefighters get called out and are a quicker response unit, particularly in rural areas. These are adaptations of the thinking and there's discussion about whether a naloxone kit and an EpiPen should be in public spaces with the defibrillator kit. And you go, yeah, why didn't anybody think of that before? Why don't they have EpiPens in there already and then add the naloxone to it? So that sort of thinking needs to be much more. I'll give you a current one. I'm in discussions with the university at the moment about why don't we have those kits in our own building? And it's a bit embarrassing. We don't have it in our own building. Now, fortunately, I hope enough of us working in the building have been on training and have it in their bags anyway. But you'd have thought institutionally we'd have addressed it by now.
I mean, even prescribing isn't entirely straightforward, in terms of kind of sending someone away from the ward with it, or sending someone that you're seeing in the community who's not, say, necessarily under an addictions treatment, but just being like, you've mentioned opiate use, let me sign you out with some take-home naloxone.
Yeah, it is interesting, and it does. I think it requires us to take a collective commitment to find the problems. Because I don't know why it's so difficult for you to do so, because the law was changed something like 8 years ago.
8 years ago.
Yeah, to permit any member of the general public to administer naloxone. So. And that was when it was injectable. So it was added to a very small list of medicines that the general public is allowed to give by injection. And that includes adrenaline, like an EpiPen and things like that. And so it was added to that list. So there was no fear that you might be prosecuted for that. And it's also, there's been a lot of effort so that it can be provided to both people in treatment with addictions problems, but people not in treatment with addictions problems and their family or their flatmates from drug agencies or community pharmacies with a very light touch monitoring. And yet somehow within lots of the NHS, somebody such as yourself is saying it seems so difficult and bureaucratic. You can't help but worry that we've allowed bureaucracy to get in the way of a common sense intervention. This isn't the only aspect where bureaucracy can get in the way, but it is worrying. One issue specifically to raise is I sometimes encounter colleagues who say, I'm worried about doing that because what if I was held accountable because something went wrong? And the first thing to say is it's hard to think of what could go wrong, because if somebody's not an opiate, not a heroin user or an opiate user or not dependent, it's extremely unlikely it would have any effect at all on them if they took it. And if one's worried about those sorts of issues, I think a much bigger worry is, what would both public opinion and professional opinion be if I didn't intervene? On what grounds did I withhold something that could have saved their life just because I wasn't sure how to do it? You sort of think we should be much more proactively viewing this as something that should be a routine part of practice unless the patient asked for it to be withheld. I think probably the most interesting thing is this empowerment issue of actually saying that the wider community, those of us who are medics and such, part of our responsibility is to impart that knowledge to that wider community. And then the wider community has the responsibility to take on that knowledge and responsibility. Rather like the history of the Heimlich maneuver or something, that if somebody's choking to death in a restaurant, if there's an A&E consultant there, then they'll probably be the one who rushes up and saves their life. But if there isn't, you'd hope that there were other citizens in society who would go, oh, I know what you meant to do here. I can stop them dying. And naloxone needs to get into that space. My personal ambition is the Heimlich maneuver is featured in an episode of The Simpsons, and I want to take-home naloxone in The Simpsons, but we'll wait and see whether that ever happens.
You've got a good track record, so I hopefully someone listening maybe has an in with the writers and gets that in.
I think teaching Homer how to put someone in the recovery position, I think it's a perfectly reasonable objective.
And probably great source for comedy as well.
Yes.
Like teenagers go on BLS courses, don't they? Like life-saving, how to do chest compressions, how to do. Why not teach how to give someone naloxone? Quite a number of my colleagues within the addictions research group that I lead, who are not clinicians, they're on the university side, have just done a 3-day first aider training, and they've been taught how to use a defibrillator. Mm-hmm. Now you go, wow, a defibrillator, I know it's incredibly automated now and safety proof and things, but that is a big intervention, and I think that should pave the way for us paying those of us who are medics, looking at, have we got more technologies that we should be sharing with the people who would be the beneficiaries of it? And this is sort of quite a good example. I wonder if I could take us back to, if you have a few more minutes, just on the rates of drug deaths and how high they are at the moment in current years. I know you talked about how extremely high they are in the US and Canada, and I think people have learnt a lot about the origins of the opioid epidemic there. Sorry, the opiate epidemic there. But I wonder if, do you have any feelings on what the British opiate epidemic, how it came about? Is it different, or why are our deaths so high? I don't know what your perspective's been.
Yeah, it's one of those questions where there are bits that I could lead you on to discuss where I feel, oh yeah, I'm on safe territory there. But actually the more interesting bits are the bits that are puzzling about it. Because, for example, whilst we do have fentanyl as a problem here, we only have really small amounts of fentanyl as a problem. Now, my colleagues might howl with protest about it, and maybe this interview will look terribly dated in a year's time when something horrific has happened. But when you look at, the US has had a major problem with both diverted fentanyl and illicitly manufactured fentanyl. And it's strange that it hasn't really featured in Europe. And in a way, those are like more interesting questions. And I don't know the answers to those. I mean, one issue that has emerged from the studies we've done, and others have done, about how do we prepare for dealing with, how do we try to intervene more constructively with it, is that these deaths don't occur randomly. There are things that we can identify times of greatly increased risk. So if somebody's been withdrawn off drugs in prison or in rehab or in hospital and is then released or discharged, or whichever term, we know that's a time of massively increased risk. So in the week after coming out of prison, somebody's likelihood, if somebody's previously been involved with heroin use, their likelihood of dying of an overdose in that first week is 40-fold increased. You go 40-fold increased compared with someone who wasn't involved with heroin use. And you go, first of all, let's try and understand that. But also as clinicians, it should say to us, not as individual face-to-face clinicians, but as sort of public health planners and people setting up initiatives and such, you're telling me that here's a group of 100 people coming out, and I know that some of them are actually going to die of an overdose in the next week. I think I better get my act together and work out how can I make sure that they and their family and the people around them know what the hell to do if they do have an overdose. I mean, hopefully prevent them getting involved with that use, but also make absolutely sure they know what to deal with it, how to deal with it if it occurs. And those clusterings, I suspect, are one of the ways in which we'll get better at intervening and reducing it. I mean, you were asking me earlier about methadone treatment and buprenorphine treatment. It's also important to realize that being in treatment is protective. Even if people in treatment continue to have some degree of involvement. So a little bit like if you were looking at smoking behavior and somebody was still occasionally smoking, you could still look at it. If you were running an emphysema clinic, you'd be saying, or a COPD clinic, you'd say, I wish they'd stop completely, but I'm glad they're not smoking regularly or like they were. But being in treatment reduces your death rate to about a fifth of what it was. So it doesn't eliminate it for everybody, but reduces the likelihood of an overdose death to a fifth. So when people say we should aggressively try to get people to quit their medication, this needs to be it really is in the clinical space. It needs to be a carefully considered joint decision between the clinician and the patient about, are we agreed we're going to work for this? And we should be saying, this has risks. You're going to go into a space where you've got a greater risk of overdose death. So let's not do it if you know you're going to relapse. But if we can help you do it and not relapse, that's a really good achievement. But it's not zero risk, which is how it's often portrayed. People say, oh, it's wonderful. It'd be great to get them clean and we know they'll stay clean. Well, if you make the judgment call wrong, it comes at a price. So that's not arguing against it. It's just arguing it has to be a considered judgment. And medicine is full of these instances. There are so many examples in medicine where you're helping the patient weigh up the balance of option A versus option B. And it fits well in that space.
Does it feel, I'm curious what you've said about the differences in fentanyl between here and North America. And I'm wondering if you were pointing to the kind of societal, environmental differences. I mean, I know you said it's a puzzle and you're not sure, but I wonder if I could press you to hypothesize on why what's our epidemic about, what's theirs about.
I'm going to fail this interview at this point of things because
no, impossible.
I think it's really puzzling, because people go, I mean, there's even sort of sociology, technology to it. You talk about the diffusion of innovation and things like that. And those are hugely interesting concepts about how does any innovation and sort of using a different drug or a different way of using a drug is an innovation in a sort of way. You can study how that spreads and how it's transmitted through different networks and things like that. It just is puzzling because in today's era, that for the knowledge or even the product to transfer, you aren't having to wait for a boat to come from New York to Liverpool and then somebody to get on a train to come down to London. Or, you aren't having to wait for a letter to come by sea mail or even air mail. You'd have thought something would happen in Chicago and someone anywhere in the world would know about it minutes later. So, and the technology is quite simple technology. So that's what makes it interesting and puzzling, because you go, wow, so there are factors which aren't as simple as legislation or customs or borders customs or and why does one city get hit hard with a problem and the next city doesn't? And you go, this is a more interestingly interwoven set of problems. I guess it's why at a personal level, why the field continues to be endlessly fascinating to me. Just when you think you've got it sorted, you realize you've just actually done the top right-hand bit of the jigsaw puzzle and you've got all the rest still to do. So I've only done the trees. I haven't yet done the sky.
So we don't know, something in the demand or the choice somewhere someone's making is affecting.
Well, yeah, and I think I'd leave it as an unknown. Partly because I don't know the answer, but partly to say we know that it can't be to do that people don't know about it. It can't be to do with the fact that they couldn't access it, because I think a postage supply, an international parcel would come in just as easily to the UK as the US. Well, I don't know that, but I assume that it's pretty similar. Other substances come in and out and cause problems. So, and we do have, I don't want to say there isn't any fentanyl here, but when you look at the extent of devastation in the US, then we're orders of magnitude different. But just on a final twist on this topic, even the fentanyl issue is sort of quite interesting, because a lot of the medical and scientific, as well as the media coverage, describes fentanyl as uniquely dangerous and uniquely powerful and therefore dangerous. And it undoubtedly contributes massively to the overdose death problem. But fentanyl is actually a medicine. Fentanyl is a medication that anaesthetists and pain specialists have been using for 30, 40 years and handling quite well. And at least part of what makes it seem so sort of evil in a sort of tabloid terminology is that because you're dealing with micro doses, small amounts you're using, that's okay when what you're administering is something that came in an ampule. so all of the dilution's already been dealt with. But the margin of error is much greater when you've got somebody just trying to put a minute amount of that substance across into a syringe. So that would indicate that it's the lack of attention to the sensitivity to dose that's going on because it's so concentrated. But other characteristics might actually be to do with fentanyl itself versus other substances. And that's part of what the scientist in me would sort of want to know, sort of which bits are to do with the illicit supply and the uncertainty about how it's been manufactured, and which bits are to do intrinsically to do with the substance, even if it was pharmaceutical diverted.
And I guess what I'm hearing, and correct me if it's completely wrong, but there's in terms of the opiate problem that the world is facing at the moment, there's something with fentanyl specifically in North America whereby, like you say, either the dose or the way that it's manufactured, that drug being so present there is contributing to the sheer numbers that part is facing. And there's some of it here, and the origins of our problems are different. But
yeah, I mean, you've very successfully led me into the zone of speculating on areas where I don't know whether it's correct. But let me since you've led me there, there are really interesting things about the different ways in which medications are used by the general public in the US and the relationship to medications compared with the UK, and where doctors fit within it. So I still find it a shock when I visit the US and there are public advertisements in magazines or on billboards for one medicine versus another. It just seems offensive as a concept, from the protected situation in the UK. And similarly, the relationship to doctors is different, where you go to a doctor often knowing what it is that you're wanting from the doctor, rather like I might go to an electrician or to a builder. Whereas in the UK, we have a very different relationship with how we have a relationship with healthcare. And it may be that was an environment in which the problem of prescription opiate problems was able to flourish more. I mean, it is a problem here, but again, we're an order of magnitude less of a problem than the US. So it needs attention. We shouldn't ignore it, but we shouldn't think it's the same as the US. The other interesting area which your comments also raise is, are these connected at all? So you've got a prescription opioid problem, which over the last 20 years has relentlessly got bigger and bigger, then led to a professional and a societal response saying this prescribing shouldn't occur. And there was a lot of turning off of the prescribing. And time-wise, it coincided then with the illicit problem getting bigger. And there are certainly people who'd argue that the heavy-handed turning off of the prescribing, which had been permitted and then suddenly is turned off, created a situation in which an illicit market is able to flourish. And it sort of comes back to the questions much earlier on in our conversation about, if you've come to learn that it eases your situation, your unemployment, your mixed with some chronic back pain and the family problems you have, whatever it is, and suddenly that way of numbing it is taken away from you, are you more likely to pick up an option of another route? I mean, looking at those becomes a hugely interesting policy analysis, quite a difficult thing quite easy to hypothesize and quite difficult to unpick whether your hypothesis is crazy or accurate.
Mm-hmm. Well, thank you for following the lead and hypothesizing because it's hugely interesting, and we can absolutely caveat it with the fact that we just don't know, but it's where questions come from. And
I think that's right. I think that it is legitimate to be having this conversation and to be thinking about whether there's odd relationships that aren't the way you thought about it originally, which is not to say they're correct, but by thinking those, you can then work out, how can I check? You can even do it looking at how it pans out in different countries. You go, oh, so they did it differently there, and gosh, the natural history of how it unfolded there turns out to be different. Those are weak scientific designs, but they might still be illuminating.
I will draw us to a close because I've picked your brains for a really long time, and I'm incredibly grateful. But I guess before I take us away, just, is there anything that I haven't asked you about, or any messages or anything at all that you'd like to bring so that we can ensure that we've not missed?
Right. I don't think you've missed anything. I think you've asked me about everything that you could have asked me about. I'd probably like a take-home message that the stigma that exists needs to be countered, and we are inadvertently part of allowing it to continue. That we, in a collective and individual sense, that we allow mental health services to be of lesser worth than other areas. Notwithstanding all of the good advances that have been made, they still are, and our voice is seen as a less relevant voice than it ought to be. And within mental health services, there are some areas like addictions which are seen as less worthy than others. And I hope that most of the people sort of listening in this conversation, if they stop and think about it, would actually think, no, if it was someone I cared about close to me, I think it's every bit as deserving as any other physical or mental health space. And if we all went away and collectively committed to address that, this would be a really good conversation to have had. It's been enjoyable anyway.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. If you find the podcast valuable, why not buy us a coffee to help keep us going? There's a link in the show notes. As ever, we love to hear from you and love to hear what you think. So drop us an email or get in touch on social media. Thank you so much.